كيف تعديل السلايد أبو محمد؟ محمد كيف تعديل السلايد؟ The next slide. Okay. We go to the next slide. How come? كذا أروح السلايد الثاني. ما شايفين ولا شيء. ما في، لو تجي تشوف الله يعافيك. الكيبورد؟ تمام. ايه الكيبورد خلاص. تمام. هلا. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. الحمد لله وكفى، والصلاة والسلام على النبي المصطفى وعلى آله وصحبه ومن سار على أثره واقتفى. أما بعد. Good morning everybody. First of all, it's the last day of Mistru, so it's time to fully appreciate the time and efforts that put together from Dr. Saad Rashidi and everyone in this conference to make this happening. This is always a very unique and phenomenal opportunity to meet with colleagues, friends, and experts in the radiation oncology. And it's a good chance for joining hands over many arguments in the fields that we all need to be engaged in. So today I'll be talking about radiation dose and booster dose after breast-conserving treatment in patients with the breast cancer. Back to October 2021, I have presented this topic in Chicago, and I found that it's interesting to be presented again at different regions of the world with different people. This topic, one of the hottest topics that's been always brought to the table of discussion among therapists, oncologists, dosimetrists, physicists, and the question that's always popped up: what is the best for the patient with this case? So let's move on to the introduction. Breast-conserving treatment has become standard for early stage breast cancer. The main purpose of breast-conserving treatment is to maintain cosmetic appearance of breast to increase patient satisfaction. Patient will receive radiation therapy as a component of breast-conserving treatment alongside the lumpectomy. Evidence shows that radiation therapy after breast-conserving treatment for patients with breast cancer decreases mortality and reduces recurrence compared to patients who didn't receive adjuvant radiation therapy. However, randomized controlled trials demonstrated that radiation dose and tumor bed boost are still varied for patients with a breast cancer undergoing breast-conserving treatment. Hypofractionated and conventional whole body radiation given for patients with breast cancer with breast-conserving treatment. Also, tumor bed boost has advantage and disadvantage. The purpose of this review is to explore the radiation dose of hypofractionated and the standard fractionated radiation therapy for use with the breast-conserving treatment. This scientific review identifies the positive and detrimental aspects of tumor bed boost in breast cancer with breast-conserving treatment. The significance of this review is to explore treatments with the best outcome. This is the figure that shows the standard setup for radiation therapy as a component of breast-conserving treatment, and this setup was verified by Astro. This is the findings. First of all, the breast-conserving treatment is a lumpectomy, and it's followed by adjuvant whole breast irradiation. A 2 millimeter margin from the ductal carcinoma site to edge allows for adequate local control when treating early stage breast cancer with breast-conserving treatment and whole body irradiation. Conventional whole body irradiation gives radiation between 45 to 50 gray in 1.8 to 2 gray in per fraction to the whole breast, with or without additional bed boost. The duration of conventional radiotherapy is 5 to 7 weeks. Across 4 studies, the radiation dose used in conventional radiotherapy varies, and it's always between 50 to 50.4 gray in 28 to 25 to 28 fractions. Hypofractionated high whole-body radiation gives radiation between 40 to 40.2 gray in 15 to 16 fractions. The fraction size is greater than 2 gray with or without tumor bit boost. The duration of treatment is between 3 to 4 consecutive weeks, and the total dose of hypofractionated whole-body radiation is radiobiological equivalent to the conventional fractionated whole-body radiation regimen. The tumor bit boost in conventional whole-body radiation varies across 3 randomized studies. The tumor bit boost used in conventional fractionated whole-body radiation was 9 gray, 10 gray, and 16 gray. But in one study, the tumor bit boost was in hypofractionated whole-body radiation was 16 gray only. The tumor bit boost is required for patients with breast cancer and who are younger than 50 years old with a high-grade large tumor, close margin, negative estrogen receptor, and extensive intraductal component. This is the figure that shows surviving fraction for single dose treatment in comparison to multi-fraction. And this is the discussion. Comparing to the efficacy of hypofractionated whole-body radiation with a conventional fractionated whole-body radiation at the 9-year follow-up show no difference in terms of local regional recurrence risk, and survival rate. Another study also identified a significant difference in 10-year local control, local recurrence, and overall survival. This confirms that hypofractionated breast radiation therapy at the dose between 40 to 40.2, 42.5 in 15 to 16 fractions for early breast cancer is adequate for local control. Hypofractionated whole-body radiation had a better cosmetic outcome than conventional fractionated whole-body radiation at 3 to 5 years. The cosmetic concerns for patients with breast cancer who underwent breast-conserving treatment include telangiectasia, dyspigmentation, scar, edema, pain, and breast sensibility. Radiation therapy planning techniques frequently used to deliver radiation are 3-dimensional, conformal radiotherapy, and the intensity modulated radiation therapy. IMRT technique can reduce the dose at 4 millimeters under the skin. IMRT technique offers a benefit. It lowers the radiation dose to the ipsilateral lung on the target coverage than 3D-dimensional conformal radiation therapy. IMRT is a technique to enhance dose homogeneity. IMRT typically uses 5 to 7 to 8 beams usually to achieve the conformality of the high dose distribution to the target volume. The advantage of the IMRT technique is that it exposes tissue in the contralateral breast and lung to lower radiation doses. 3D conformal radiation therapy is a technique that has treatment fields pressed on 3-dimensional target volume, contoured on axial CT rather than on surface anatomy, skin decision, 2-dimensional image on the bony anatomy, and critical organs at risk. A beam arrangement using a 3-dimensional conformal radiation therapy includes a parallel dose photon, tangent field to treat a breast or chest wall, low auxiliaries, and internal mammary nodes. The anterior photon field is used to treat the high axillary and supraclavicular node, which is of material designed to absorb radiation that might be placed in the beam's path. This is the figure that shows the differences in dose distribution in an MRT and 3-dimensional conformal radiation therapy. Continuing to discussion, tumor bit boost had benefits for younger patients with breast cancer, patients with a high-grade tumor, and patients with a negative estrogen receptor. Even though the tumor bit boost varies for clinical practice, a tumor bit boost of 10 gray in 5 fractions following standard fractionated whole-body radiation to a total cumulative dose of 60 gray has been commonly used. In hypofractionated whole body radiation therapy, the tumor bed boost was delivered approximately 10 gray in 4 fractions. The advantage of the tumor bed boost is in improved local control. On the other hand, some studies showed that tumor bed boost causes a poor cosmetic outcome, dermatitis, and arm-shoulder dysfunction. This is the outcomes of hypofractionated and standard radiation therapy. Recently, in retrospective analysis of 143 patients with breast cancer, the findings showed that patients who received hypofractionated whole body radiation with a boost reported having delayed toxicity, including post-radiation volume loss and fibrosis. Approximately in this retrospective analysis, 96% of samples had a good cosmetic outcome. These results are indicated in figure 4, which shows the difference in percentage outcome between hypofractionated and standard fractionated. This figure was created by me. Here we go with the conclusion. Hypofractionated whole body radiation is often used to effectively shorten treatment time, but even though reducing treatment time, it still results in positive outcome when compared with the conventional fractionated whole body radiation. Hypofractionated whole body radiation had a good result for local control and overall survival. In addition, the radiation dose in both hypofractionated whole body radiation and conventional fractionated whole body radiation varied, and the tumor bed boost was also inconsistent in both hypofractionated whole body radiation. And the conventional fractionated, the tumor bed boost was shown to have benefits for young patients with breast cancer, patients with high-grade tumor, and patients with negative estrogen receptors. However, patients who received tumor bed boost have been shown to experience more toxicity, such as dermatitis and shoulder dysfunction. IMRT techniques and 3D conformal radiation therapy are types of treatment planning used for hypofractionated whole body radiation and conventional fractionated whole body radiation. IMRT always provides better conformality of the high dose to the target areas than conventional three-dimensional conformal radiation therapy. And it reduces radiation exposure to the contralateral breast and lung. Conventional fractionated whole body radiation gives radiation between 45 to 50 gray in 1.8 to 2 gray per fraction, while hypofractionated whole body radiation gives radiation between 40 to 42.5 gray. And the tumor bed boost varies depending on patient's medical characteristics. Based on this review, a boost to conventional fractionated whole body radiation was 9 gray, 10 gray, and 16 gray, whereas boost has hypofractionated was only 16 gray. So the main goal of the tumor bed boost was to increase local control. However, the side effects of the tumor bed boost are controversial still. For future study, randomized control trials are recommended and required to examine the long-term advantage between hypofractionated radiation therapy and conventional radiation therapy, with or without bed boost among breast-conserving treatment patients. These are my references. Thank you so much for joining me today. For any questions or inquiries, this is my email and phone number. And thank you so much.